Hello, everyone. I hope you all doing great. Let's study together respiratory system examinations. And the examination itself, it's very easy in terms of step. So steps wise is easy. I can just tell you the steps right now, like just in summary. Uh, Inspections, and we have the like general look for the patient surrounding and for the patients, and then look for any obvious respiratory distress, and look at the patient's hands, and from the hands we go to the pulse, and then polar jaundice in the eyes, and look for any systemic features in the face or in the hands, and go down to the neck. In the neck, we have the trachea, we have the cricoid notch distance, the cricosternal notch distance, we have the tracheal tug, we have the JVB, and we go down, we inspect the chest anteriorly, and we do palpation 3 times. We put our hands 3 times for chest expansions, chest percussions, and tactile vocal firmness like 99s with our hands. And then for sculptations, we do two steps. We ask the patient take deep breath in and out. And the second sculptation, we ask the patient say 99 every time we place our stethoscopes. In the chest anteriorly, we repeat the same steps in the chest posteriorly and check for lower limb edema. This is in summary. So the steps sound to be very easy, but honestly, the respiratory stations in the basic exam is the most difficult one. You can easily fail it, you can easily miss it, you can easily miss vital signs which could lead you to the diagnosis because there is similarities between the most common stations that come in the exams. There is very close similarity in the finding which could make you get the whole station wrong. For example, the bronchiectasis and interstitial lung disease, the crackles, it will be very difficult in the exam stress to know if it's like coarse or fine crackles and change with coughing or not change with coughing. It's very tricky, okay? And for example, lobectomy or pneumoctomy is very tricky in the exam, especially with the stress, to remember if this really lobectomy, like was it the signs, was it localized to the certain area, or was it all all the signs in the for example right chest wall in the right side, all like all the signs are reduced vocal parameters reduced, chest expansion, uh, dull on percussions on that side, all of it, and should it be like pneumoctomy? And it's tricky because even like pneumoctomy, the trachea will be deviated to the affected side, so you'll have bronchial breathing in the top. So we'll hear some breathing sounds. So you will be confused. Is it pneumoctomy? Is it uh, pneumoctomy or buloctomy or lobectomy? Sorry. So let's go like when you start your respiratory stations, try to collect as many clues as possible. Stay calm from the inspections. Look up for clue to tell you what station is it. There is no too many stations coming in the exams, the good news, but still you need to focus to know which the diagnosis. Because if you got the diagnosis right, you pass the station. If you got it wrong, you will fail the stations. So let's start from the beginning. So we will start, of course, by introducing ourselves. Hi, my name is Dr. Ahmed Al Hadi. Is it okay to examine you? Asking for permissions, very important. And ask, do you have any pain? And this is apply for all short clinical examination stations in the basic exams, like introducing yourself, asking for permission and asking for pain, and ask, do you have any pain anywhere? And during my examination, I will try to be as gentle as possible, but if you feel any pain or discomfort, please let me know. And then you start by having few step backward, like just acting to the examiner, showing them you doing general inspections from the bedsides, and have a look to the patients. And don't look randomly or just doing nothing. You have to make use of every second. The time is very limited, very tricky, so make use of every second and try to look for clues that could help you reach the diagnosis. So from the inspections, the first things you focus in is the patient is breathless at rest or not breathless. Is this patient comfortable or seem to be in any kind of respiratory distress? It will be very obvious for you. And and is it cachectic or well nourished? So could be cancer, could be chronic disease. So look at the general inspections, and we will start before you looking at the patients. Start just by the surrounding. Look if there is any medications at the bedsides. It will help you to reach the diagnosis. They put it for you. They put inhalers to tell you this patient has background of COPD or asthma. They will put for you list of medications sometimes to read out, and you will if there is sputum bots like clues, this patient might have bronchiectasis, and um, and also, for example, if he has oxygens, so he could have COPD, advanced COPD, or have interstitial lung disease. Okay, so now you had a general look. Before you go close to the patient, ask the patients two questions. Could you please take deep breaths in and out for me? And when he take deep breaths in and out, watch the chest wall movement. Do they move symmetrically or asymmetrically? And if they move normally, maybe reduced bilaterally. So if the movement is reduced bilaterally, it could be advanced, for example, interstitial lung disease, or it could be COPD. If it moves less in one side, you could have pneumotomy, you could have like interstitial lung disease more in one side, so or could have massive pleural effusions. So try to find out if there is the chest wall move less or more in one side. Comment in your head about the chest wall movements, and ask the patient to give you a cough. Could you please give me a cough? And if he has dry cough, it could be interstitial lung disease. If you have productive cough, it could be either pneumonia or bronchitis. Then go close to the patients. Start with the hands. In the hands, focus on the fingers. So first, we will be looking for clubbing, clubbing. For example, this patient has bronchiectasis, or has cystic fibrosis, or has a cancer, or has interstitial lung disease. If he has clubbing, and if this patient has rheumatological disease such as rheumatoid arthritis, he has deformities in his fingers, like swan neck deformity, Z shape, thumb, or ulnar deviations, or if this patient has systemic sclerosis, features in the hands which arachnodactyly or tied thick skin, uh, and also in the fingers, we need to look for nicotine stainings, and we need to remember 2F fingers and 2F. 2F, what are they? Fine tremors and flapping tremors. Please don't forget, because it could be this is the main clue or the main positive finding in your stations. So fine tremors for beta 2 agonist overuse medications such as salbutamol, and give you clues. This patient could be asthma, it could be COPD, and or tacrolimus side effects, this patient could have lung transplants. And then flapping tremors. So we'll ask the patients for the hands. For fine tremors, would you please stretch out your arms like this and demonstrate for them, and spread your fingers like this. So you will look for fine tremors and you ask them again, would you please cock your wrist back, looking for flapping tremors, which signs of CO2 retentions. Um, so flapping tremors is always signs of uh, failure, like either respiratory failure or liver failure, or um, the main organ like respiratory, renal, or livers. So if this any of this organ had a failure, the patient will have flapping tremors. Hepatic encephalopathy will cause flapping tremors. Um, Hyperuremia, like renal failure, will cause flapping tremors, and respiratory failure, which is CO2 retentions, will cause flapping tremors, right? So, and then we can look for steroid overuse, because if the patient has interstitial lung disease or has COPD or uncontrolled asthma, they may be using steroid for long terms. So we'll have it steroid side effects like thinning of the skins, or you'll have purpura in their arms and in their hands. And we done with the hands. So we said in the hands, focus on the fingers, starting by the nails, looking for clubbing or nicotine staining. And then look in the finger for any deformities, to look for any rheumatological disease features such as rheumatoid arthritis, systemic sclerosis, or SLA. And then we finish with the fingers, and we look for 2F, fine tremors and flapping tremors. Going up, we go and check for the pulse, and specifically characters. We will find if they have COPD, they will have bounding pulse, which is like due to CO2 retentions. And then also we can ask for blood pressure measurements. So we're done with the hands. We go up to the eyes, looking for jaundice and pallors, and mouth for cyanosis. We can look in the lips and ask the patients to, could you please raise your tongue or lift your tongue, or stick your tongue to the roof of your mouth and look under the tongue for cyanosis. And also in the face, we can look for any systemic disease manifestation. If you watch it, like maybe like SLE rash or sarcoidosis rash, like lupus pernio, or any features, telangiectasia, whatever. Like you, if there is anything noticeable in the face, you could make note of this, and then go down to the neck. In the neck, we have the most important things, not to forget the trachea. Is it central or deviated? And we need to keep notes if it's deviated, to which sides. Is it deviated to the right or to the left? Because trachea could be pulled by collapse, pulled by fibrosis, and could be pushed away by massive pleural effusions, and could be also like deviated toward the pneumectomy sides. And then go in the, also we have the crico-sternal notch distance, which ideally has to be around 3 fingers. If it reduces, is a sign of hyperinflations, which is in COPD patients. And then we do the JVP. Ask the patient, would you please look at the left side or turn your head to the left side and look for any signs of increased JVP, And if you find it any JVB wave, ask them, do you have any pain in your tummy? Can I press and press on the hepatic area for hepatojugular reflex? And also we need to check for lymphadenopathy in the cervical and axillary area. And then you go down to the chest, anterior chest wall. So in the anterior chest wall, by inspection, most important thing to look for is scars. And we can find the clamshell incision scars, which is very long scars under the rib bilaterally, which for bilateral lung transplants. A lung transplants could be for cystic fibrosis or for interstitial lung disease or for COPD. And then as I said before, we have chest expansions and percussions and 99 cerebral patients. So for chest expansions, we need to focus on which area is there is reduced chest expansions. As I said, like it could be pneumoctomy, it could be interstitial lung disease, and or could be reduced bilaterally, like in COPD. And then when we finish with chest expansions, we need to do the percussions. And we'll be keeping a note again by is it dull on percussions? The normal should be resonance. Is it hyper resonance as in COPD or dull in percussions as in pneumotomy or fibrosis or collapse or consolidations? And then we'll put our hands by the radial side and ask the patient, would you please see 99s? And the most important part with the chest auscultations, and we need to do chest auscultation 2 times. So we ask the patient, would you please take deep breaths in and out every time I place my stethoscope in your chest? And then ask the patients to say 99. Would you please say 99 every time I place my stethoscopes in your chest? So the most finding will be in the back. So especially the auscultation is easier from the back. So you need to be faster in the front and give enough time to examine the patient from the back. And normally, like for the areas of like auscultation or chest expansions, you need to, for example, for chest expansions, start from the lower part of the chest anteriorly, because most of the station, the finding will be in the lower part. So it starts in the lower part and do another one just in the center of the chest. So you start do as the patient take deep breath in and out while you holding their chest with your fingers and keeping the thumb free to look for chest expansions, and start from the lower part. And we see if the symmetrical decrease chest expansion, for example, in severe interstitial lung disease or hyperinflated lung, such as severe asthma or emphysema. As I mentioned, you have to keep notes with every finding you're finding and try to stay calm because stress can take everything from you. And for tactile vocal perimeters, for example, as the patient C99s, also we need to check in 3 areas. We can do one above the nipple, one within the nipples, and one below the nipples. So increased tactile vocal perimeters in consolidations and decreased in pleural effusions. And we go to the percussions, also in 3 areas, and we need to compare bilaterally. Like always, when you do anything, you have to compare the same side in the other chest. Right and left, you have to compare in the same sides. So compares bilaterally, and you can do start percussion in the clavicles, and then lateral to the nipples, and then below the nipples. So in the percussion, try to move more laterally. Um, so go lateral to the nipples and in the axillary area as well, yeah, below the axillas. For example, as I said, dull percussions in consolidations and stony dullness in pleural fusions. And then in the auscultations, we also need to auscultate above the nipples and lateral to the nipples, same area as percussions, bilaterally. And can you please take deep breath in and out for me every time I place my stethoscope, as I said. And then if you find any crepitations, you need to ask the patients to cough and see if these crepitations change by coughing or not. If it's changed by coughing, it means it's bronchiectasis or maybe congestive heart failure. Like changing by coughing, it means there is fluid. When he coughs, the fluid moves from the place, so we'll find there is change in the coracoles. But if the patient has interstitial lung disease, he has fibrosis, it's not going to change if the patient coughs. And we examine the posterior chest wall. The most important things in the posterior chest wall is scars. You need to look for the scars. Lateral thoracotomy scars, which is in the lateral. You can see part of it when you examine the patient anteriorly. But when the patient sitting, it's very clear. You can see it from the back, lateral thoracotomy scars. If you see these scars, we have either pneumoctomy or lobectomy. This is our differential will be. And if you find the scars, you need to concentrate very well if this patient has localized signs just at the scars area, or it could be even like in the upper loops or in the middle loop, in the lower loops, if the patient has a recent lobectomy. So you have localized uh, signs like reduced percussion notes. There will be dull percussions, and there will be reduced breathing sounds, and will be reduced vocal fermitas. But if the patient has a pneumoctomy, it will be throughout uh, reduced breathing sounds and dull percussions, and reduced vocal fermitas throughout the all the, for example, left chest wall, all the sides. But you have to be, as I said, very careful with that. And you have to remember that the trachea will be shifted in pneumoctomy. So you may hear bronchial breathing in the upper part of the chest, but will be reduced in the lower part. So be very careful about lobectomy and pneumoctomy. We could also find the video assisted thoracoscopic surgery scars, which three scars, one of them around like 5 to 6 centimeters, and then two other small scars. It will be three scars. This is video assisted thoracoscopic scar surgery scars, which is vast. In short, it's VATS. And video assisted thoracoscopic surgery, it could be indicated for many reasons, such as lung biopsy, or even for lobectomy. They can use it to do lobectomy, but never for pneumoctomy. For pneumoctomy, we need big lateral thoracotomy scars. And we repeat the same steps: chest expansion, chest percussion, chest auscultation, and try to avoid the scapula area. So do above the scapula and between the scapulae and under the scapulae. And the most important thing, the auscultation, especially in the lower part, because you might find crackles, and we need to know if these crackles find inspiratory crackles, which indication for interstitial lung disease, and it will not change by coughing. We ask the patient to cough, as I said before, and if they change by coughing, it would be bronchiectasis, and it will be coarse crackles. So the bronchiectasis coarse crackles which altered by coughing. For interstitial lung disease, fine respiratory crackles, not not altered or not changed by coughing. We can check for sacral edema and lower limb edema, and it's just a matter of time. But if you find the GVB, for example, raised, remember to look for other signs of pulmonary hypertension, which is like left parasternal heave, palpable B2, and lower limbs edema, and also basal crackles. And also you can have like tricuspid regress is also signs of pulmonary hypertension. But as I said, make your focus into find the right positive finding, which makes you reach the diagnosis, and then all the examiner question will be based on your finding, and all your result will be based on identifying the correct signs. I hope this is useful, and best of luck, guys, and see you in another video.